Okay, take two. Welcome, everyone, to our Brain Health and Wellness Initiative series. Tonight, our presenter is Dr. Elizabeth O'Toole, and she is presenting on behavioral and psychiatric symptoms associated with dementia and possible treatments. My name is Courtney Kelly, and along with my colleagues Hannah Doles and Cassie Fazekas, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those who have dementia, are at risk of developing dementia, while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance of working with our clients' strengths and applying a person-centered approach to care, which extends throughout our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Cassie, Hannah, and I meet our clients where they are at and develop individualized care plans that help produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management, we are their point of contact for guidance as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. If you think of a question during our presentation tonight, please type it in the Q&A section and not the chat. Towards the end of the program, I will be presenting the questions to Dr. O'Toole. And then we also offer one continuing education credit for these discussions. It will take 30 days from the date of your application and completion of the survey to issue your credit. Your certificate will be emailed to you at the email address you provide during registration. The email address that you use to access this webinar must be the same as the one you are providing. Entering a different or incomplete email address will prevent your CE from being issued. If you're unsure of the email you used to attend, check your original confirmation email. So our presenter tonight is Dr. O'Toole. She graduated from CWRU School of Medicine and completed residency in internal medicine, with fellowships in general internal medicine, clinical ethics, and geriatric medicine at University Hospitals of Cleveland and Cleveland VA-MC. She has been a professor of medicine and bioethics at CWRU School of Medicine. Dr. O'Toole has over 30 years of experience in medical practice, focusing on geriatric medicine and palliative care, with an overall goal to provide patients and families with individualized care, education, and support. Dr. O'Toole has practiced at University Hospitals of Cleveland, the Cleveland VA-MC, and most recently at Metro Health Medical Center, where she started and directed their division of palliative care and initiated the hospice and palliative medicine fellowship program at CWRU Metro Health. She has also worked in and directed multiple externally funded research and educational programs. In addition, Dr. O'Toole has been involved in education at CWRU and other programs, as well as care through many community-based programs. She has been a geriatric consultant for JFSA Cleveland for several years. Okay, I will now turn it over to Dr. O'Toole.
Okay, thank you, Courtney. Welcome, everyone. I'm happy to have a chance to talk to you tonight. I know this is a subject that is so important to caregivers. I also know it's a subject that this series has addressed in a couple of different times in a couple of different ways. So some of what I say may seem familiar, and hopefully if there are issues that we miss, somebody will come up with the question at the end and we could entertain it. That would be great. Sometimes it's hard to guess what the right tact is to take when there's so many things that can go on. So our overall objective is to empower some thoughtful consideration of behavioral and psychiatric psychological symptoms in dementia. Meaning, with information and maybe a little bit of perspective, it might be helpful for somebody who's in the throes of dealing with a difficult situation to be more thoughtful in thinking about it. We'll review key features of dementia, which will be reviewed, and possible treatment approaches that are sometimes tried. And recognize the adverse effects and risks related to some of these symptoms and treatments. Okay, Courtney? Thank you. Okay, we just talked about that, so we don't have to go over it again. Okay. So first, just as a review of the key behavioral and psychological symptoms that we see in dementia, this is seemingly an exhaustive list, but it isn't. There are people who come up with other symptoms, but these are the ones that we see with frequency and I think will resonate with folks. Agitation, abnormal motor behaviors, that is moving, abnormal movements, anxiety, irritability, delusions, often paranoid. These are fixed ideas that you can't shake you can't get people to shake. Hallucinations. Next slide. Incontinence, vocalizations and screaming, sleep disorders, can be too much, can be too little, can be a mixed situation. Appetite changes, again, too much, too little, variable. Depression or apathy, wandering. And now a little bit of background context about why this is such a big subject and a big topic. The worldwide prevalence of dementia is increasing, and that's actually been in a lot of the regular press recently. As the older population increases, so does the number of people with dementia, and it's unclear if the projected increase is just related to age or perhaps just an increase in the occurrence of dementia. But in 2016, there were 43.8 million folks affected by this, which was 117% of an increase since 1990. And those of us who have been around for a while feel like 1990 was not that long ago. So this is pretty dramatic. 5%, no, I'm sorry, 5%. It is, in fact, the fifth leading cause of mortality, dementia, which is significant because 5 is a pretty low number in terms of leading causes. It's right up there. But also because a lot of people who have dementia die of something other than dementia. So cancer, cardiac disease, strokes, other causes of death are not listed for many people who die who happen to have advanced dementia. So it probably is an underestimate. The majority of those with dementia experience behavioral psychological symptoms are related to that dimension at some point. So that's a majority of people, of a large number of people. Most community dwelling individuals with dementia are affected by at least one symptom, and some of that majority are affected by more. Next. Now, some of the symptoms that we're going to talk about tonight, the more behavioral and psychologically based ones, delusions, agitation, abnormal motor behaviors, that's like fidgeting, not just fidgeting because you're a little restless on occasion, but like fidgeting without any cause, without any control, and frequent. Repetitive behaviors, things people do over and over and over again, not purposeful. And wandering, which we also have talked about. These things occur in about a third of patients who have dementia. Sundowning, which we have also, sundowning, which we have also talked about, I think, as a group, is very common. It's not a technical term. It just simply describes these kinds of disturbing symptoms that tend to occur more towards the end of the day or late afternoon. And they occur in up to 2/3 of patients with dementia. That's very significant. That's a lot of people. And when we talk about these symptoms, it's important for us as providers and caregivers and all who are involved in this care to think about the fact that when we talk about what patients are going through, it means their caregivers are going through something, not the same symptoms, obviously, but something related to the fact that the patient has the symptom. Next, please. So since we're trying to empower thoughtful consideration, let's look a little more broadly about what behavioral and psychological symptoms of dementia are associated with. They're not just simply symptoms of a disease, but they're also symptoms of progressive functional decline. So it's, in some ways, it tells us that things are changing, which is obvious, and they're changing, obviously, in a negative way. And this, well, there's a variability in the symptoms of dementia. Generally, over time, there's a progressive change in a negative direction. Excuse me. Obviously, it's associated with worsened quality of life of both patient and caregiver. Increased caregiver stress, for sure. And it often leads to nursing home placement. That is often the trigger. It's just, we can't do this anymore. Neither the individual nor the care providers can handle things anymore at home. Excuse me again. So we're going to talk a little bit about the appropriate response to such symptoms, identifying underlying causes that are amenable to some reasonable approaches that aren't too challenging, somewhat challenging, and assessing treatment plans are very important. So when you try something, what happens? So sorry. And this is with taking the cough drop. My apologies. So I want to stress a little bit that history is important for all of us to understand what's happening with an individual and being able to plan an approach that makes sense. We just listed a whole litany of various symptoms that people have, but not everyone has all of them. Most people don't. So understanding what this individual has experienced and has demonstrated is really important, along with understanding what's going on at home. So as we go through this, I hope to give you a little reinforcement as to knowing what to look for. So whoops, did I do that? No. Thank you. So that caregivers can be able to describe their issue. It's not easy, certainly in the throes of an experience of an agitated person, maybe personally painful for the caregiver, to take the minute to think about how would I describe this behavior to somebody who's going to try and understand it, who's not in the moment with this behavior, and this person is also going to try to make a recommendation. So being able as a caregiver to describe the issue, the nature of the behavior, the characteristic symptoms you're seeing, the urgency of the need for intervention. How desperate are we? How much of a burden is this? Potentially reversible or exacerbating factors. And we'll talk a little bit more about this, but is there anything in the context when these things occur or recur that seems to be associated or predictable or makes it worse? Things that ideally one could reverse or at least ameliorate in some way. Our overall goal is always to improve the quality of life and patient caregiver satisfaction, or individual affected and caregiver satisfaction. Next, please. Since we're talking about empowerment, we're going to review what the things are that might contribute to causing the changes seen in dementia. These aren't necessarily intuitive, although some of them may be, but it helps to know what they are. Consider thinking about treatment approaches when confronted with things, or later on when you have a chance to be thoughtful about it, and write it down. Bring it to the attention of the provider or other professional caregiver. Because the ideas of family caregivers and other caregivers are generally awesome and relate so personally to the individual and their environment that the providers will not be privy to. We don't want to create care plans that are pro forma, or, I looked it up and this is what it says to do for this. We want to create care plans that work for individuals because of who they are, and discuss adverse effects and risks related to some treatments. Information is always power. Next. A little bit of information about what actually happens. And as common as we've already said this disorder is, it's quite variable individual to individual. And although it's been around for many, many years, we're still learning a lot about it, and we still don't. Obviously, we don't have answers, but we still don't really get the total picture. But I'll share with you some of the big consensus ideas about it. So the big thing is loss of neurons. Neurons are nerve cells. Nerve cells do a lot of things. Obviously, the brain is a lot of nerve cells, and that's the big issue in dementia, but also motor neurons, which are throughout the body, that have to do with movement and carrying signals for sensory and other things that nerves do. Neurons receive sensory input from the outside world. Like I'm looking out the window now and I'm seeing rain. That's my sensory input is giving me an idea of what my outside world looks like. So think about what happens to the person with dementia who is getting signals. What kind of signals are they getting, and are they like the rest of us? If you're getting the wrong signals or interpreting them wrong, you're not going to be able to do what we would do with the information. They then send motor commands to muscles and transform and relay electrical signals at each step of this communication. So it's not like A to B to C. It's A to A2 to A4. It eventually gets to B and maybe B1 or B2. So at every level, there are multiple connections that have to be made and multiple functions that have to occur. They're involved in complex information processing, integrating the input from various brain regions, which contribute to higher order cognitive functions. And then that has to be translated into various signals and chemicals that get sent to the other parts of the brain or body that have to actually perform a function. Next, please. So you can see there are a lot of places where things could go awry. In fact, when I was studying medicine, it struck me, and many people, I'm sure, how does it ever go right? These things are so complicated, so many ways that things could go wrong, but they don't for the most part. We have flexibility and tolerate as human beings. Our bodies and our minds tolerate a lot of things that are not quite right. But dementia is over the top on this, and so we see negative outcomes. You've heard of the idea of neurotransmitters, I'm sure, if you've read anything about dementia, particularly, well, any dementia, but Alzheimer's for sure. Neurotransmitter pathways are critical in behavior and cognitive function. And I'm just here on this slide, I just talk about 3 types of systems that involve neurotransmitters, which are chemicals that are created by cells that are the communicators to other cells to create function. There's a cholinergic system. Acetylcholine is the main chemical here. Those are important for learning, attention, and memory, as far as we know. There's a serotonergic system. That's important for regulating sleep, mood, and emotions. And there's something called the noradrenergic system that controls norepinephrine and other chemicals, which are involved in other things besides neurocommunication, and the neurocommunication that involves the heart and other parts of the body. So these are three big systems, certainly in the body, but not exclusively the only ones. And you can see how complex things are to have things go the right way. Next, please. So what is the impact on neurotransmitters? These systems contribute, as we said, to the network of brain function, and they influence other systems, and even more complicated, they influence each other. So changes impacting production, and often in Alzheimer's, neurons die, which usually ends up being a lack of production, but sometimes can change other production. The availability or function of these have significant effects. So this is really some of the same things that we just mentioned, but you can see on this chart that a lot of what we are seeing when we have for patients with dementia issues are managed by these chemicals. Depression, compulsion, memory, alertness, concentration, energy. I did not discuss dopamine, but dopamine is another big one, and that has to do with reward, motivation, and also some movement. Next, please. Okay. So I'm figuring that you knew this already, and if not, I've convinced you. There's no single cause. There's nothing we can point to that says this is what brings us to the point of dementia, or this is what kills the neurons. We talk about tau and beta amyloid, which have been much in the news of late. These are really things that we know that occur in Alzheimer's type dementia. We know that they get worse in Alzheimer's type dementia, and we know when scientists look at it, that they block the function of neurons, and therefore the main functions that we just talked about are not happening as they should, and the results are somewhat predictable given where the insults occur as to the symptoms that we see. But we can't, if we treat with the newest types of medications that we've talked about before, I think, that the FDA had recently approved to reduce amyloid, pretty much. They're focused on amyloid, beta amyloid to be specific. We're treating something that we know happens, and we know how it might affect Alzheimer's. We have no idea what actually triggers the amyloid to do what it does. We don't have the upstream cause of this horrific malady, but we do have some understanding of some of the more close-in issues that maybe if we interrupt that system, we can make some progress. However, the studies on these new drugs, they're helpful. It's good. We have something when we had nothing. That's a good thing. But what they give is they don't change the ultimate issues, but they do in some ways and in some people change the time frame of progression, statistically speaking. Behavioral and psychological symptoms in dementia is also likely related to interaction between the individual's complex biology. So sorry. And function, because we all have our own makeup, our own systems, and no one is the same as another. So there's a lot of variability. So as complex as these things are, you can only imagine that they would be, the complexity would be enhanced by individual change and environment. And as all psychological things really turn out to be, our experiences do impact how we feel about things, how we interpret things, how we respond to things. Without a known cause of such complex symptomatology, there are some pharmacologic treatments that are directed at presumed contributing changes, as I described for the newest drugs. Responses to treatment, though, vary, as do the side effects and reactions. Next, please. Let's think about treatments and what we ought to be considering. I can sort of imagine they're saying, oh, yeah, we know all this, but I can't in good conscience not talk about it because it really is the key thing. Non-pharmacologic treatments are recommended as first-line approaches across the board. Even the scientists who back and are proponents of treatments medically with pharmacologic agents first try the non-pharmacologic treatments. And in fact, if you do turn out to need some pharmacologic involvement, continue the non-pharmacologic treatments as well. There's not an either or. There is no clear recommendation made for any pharmacological treatment. There are recommendations made based on studies of what this particular treatment could do, but no overall declarations of, if this happens, give this. Some medications are used when non-pharmacologic interventions fail. Symptoms are extremely burdensome or even dangerous, and decisions have to be made based on a risk versus potential benefit assessment. And that's where careful, thoughtful consideration really has to happen. Pharmacologic intervention may have significant negative side effects, which is part of the calculus, part of the figuring out of what's important to do and what's more important to do. Next, please. Okay, so I want to talk about just a few of the drugs that are fairly common. There are others. Just to give you an example, when doctors prescribe medications, we often will tell you obviously what we're responding to with this medication, that's the indication. And also, we're supposed to say what the side effects are to consider. And you can look at some medications and the side effects, is half the page or even more, which isn't really something you can tell people very easily because it's overwhelming and nobody knows what to make of it. But we should tell people about some of the side effects, particularly the most worrisome ones or the ones that are most common. So lorazepam, or Ativan, is in a class of medications called benzodiazepines. And they basically a treatment for anxiety as a psychological term. But in dementia, occasionally it's used for anxiety that's not related to, I'm worried about something, but I'm having a lot of trouble coping with what's going on because I can't interpret it right. The side effects to consider for these kinds of drugs are falls with fractures, drowsiness, dizziness, weakness, unsteadiness, all of which are contributing to those falls, cognitive impairment, mood changes, dulling the mood usually, so depression is the concern, potential withdrawal, that is, if you stop it, something people have been taking for a long time on a regular basis, this is in a class of drugs that people can have a withdrawal reaction to, and paradoxical effects, which means we're giving this drug for anxiety, but sometimes we can make people more upset, more angry, more agitated, more stressed. These are not, obviously, we wouldn't even consider doing this if these things were common. They're not the most common things that happen to people, but common enough that we should let people know about them. Next, please. Okay. The next big group of medications, is particularly in agitation or aggression, are called atypical antipsychotics. There are typical antipsychotics, which we use less often now in favor of the atypical antipsychotics. And these are used in moderate to severe Alzheimer's disease. Some of these medicines are called risperidone or Risperdal, olanzapine, quetiapine. Olanzapine would be Zyprexa, quetiapine, it would be Seroquel, aripiprazole, I can do this, and zypresidone. I have not used, the latter two are not commonly used in our practice. The indication for these is agitation in dementia is one, but that's only approved for short term, 6 weeks. Often these symptoms go on for much longer than 6 weeks. It's not a cure, it's a control. There are off-label, which means it's not technically approved for the medication is not technically approved for a certain use, but people use it because it seems to be helpful in some patients. And the studies have been done to at least show some safety, at least for the 6 weeks. So off-label uses include agitation and aggression, psychotic or behavioral symptoms, hallucinations and delusions. Hallucinations are one of the markers of psychosis. They can be auditory, meaning you hear things, or visual, meaning you see things. The side effects here are different in some ways, similar in others. The big difference is these medications all carry what's called a black box warning for their use in dementia-related psychosis. And these risks include an increased risk of death and an increased risk of stroke. And the additional side effects that we talked about before can also be seen, along with some motor changes. So this, oh, sorry, can you go back for, oh, then it's all right. We can go on and we can, thanks a lot, Courtney. Just go ahead. Next slide. Okay, so here's an example. Risperidone or Risperdal is approved for persistent aggression in dementia for 6 weeks and has all the above issues, plus falls, movement disorders, some metabolic changes, and by that we mean some people have weight gain, increased appetite, a high blood sugar, a high cholesterol. Other people are more sedated or drowsy, have dizziness, orthostatic hypotension, which means that we lose our blood pressure, drops when we stand up, which can contribute to dizziness and falls, and dry mouth. Next, please. So having said all that, we do use those meds. We use them because of a careful assessment of risks and benefits. It comes times for some people where the current environment of their mind and their behavior is really just untenable. It can't be, they're distressed, caregivers are distressed, it just, can't be supported. So we sometimes have to make choices to give a try of some of these things that might improve that situation in the hopes that we can achieve a better quality of life. In the meantime, and up until we do that, we want to continue with patient-centered issues or patient-centered approach. including the ones that you know about for non-pharmacologic responses. First thing we want to be doing every time that there's such an issue is checking on the affected behavior. And they can include a wide range of things, which is why I mentioned previously, it's really useful to write stuff down so that when you're talking to a professional caregiver or provider, you can help them understand what you're talking about. So is the issue a feeling thing? Are people being sad? Are they fearful? Are they stressed? Is there more confusion or anxiety? Because the behaviors come from something. People pacing, people yelling, people resisting care, that comes from something. Can we get any bead on what that might be in terms of what they're feeling and how they're responding? Because as we know with dementia, they're not going to be articulate about what's driving them crazy at the moment, what's making them so distressed. But caregivers sometimes can clue in if they take a minute to think about it, maybe more than a minute. There are physical or health-related problems. Is the person actually sick? Is there some reason that they can't articulate for us that they don't feel right? Something is wrong. Do they have pain? Do they have discomfort? Is there a new med or a change in meds or a lack of sleep that's happened recently that's triggering all these things? And it's a good idea to seek medical evaluation for any physical or medical concerns, or even if there's a big change and not a real good understanding of whether it's a physical or medical concern. If there's a possible injury, then that's a real problem for people who can fall and maybe get up themselves, or who can bash an appendage, a hand or something against something, and there's no bruise, we don't know, but they're acting like something is awry. Maybe they have an infection. Maybe they're just plain constipated, which is no small thing. I mean, most people in life have had a problem with constipation, and nobody thinks that's a good idea. Hunger, maybe they're hungry, maybe they're thirsty. Maybe there's problems with seeing or hearing, so they're misinterpreting what's being presented to them. Check out the environmental issues, because these are things that the providers won't know. Does too much noise seem to trigger something? This is a big challenge in households or even when the individual is hard of hearing. If there's a hearing deficit, things get turned up, but it's hard to know how high is too high. Or people talking at once can be extremely confusing and overwhelming. And then people may just start to interpret that people are talking about me. I'm not in this picture. They're conspiring, whatever. Is the lighting wrong? Too light or too dark? It might not be wrong for other people, but might be wrong for this individual. A change in environment. Does something look different? Are there different patterns? Is the surface different? I don't like to go to this place because I have to climb. Does going up a step make it weird for me? Is it going from carpet to linoleum or brick or something else? Things that we take for granted and don't think twice about. Mirrors. I've never been a fan of mirrors, to be fair, but environmental elements like mirrors can cause people to have real distortion of understanding their environment. And if you have two mirrors, then it's really crazy. You're getting a mirror image of a mirror image. Those kinds of things can be really tough. But thinking about them makes a big difference. They can be fixed. Next, please. Okay. Wandering and agitation, which is a biggie, perhaps one of the biggest. Maybe we need to change the surroundings. Why, is there any way to tap into what we think they're wondering? Why are they doing this? Are they misinterpreting something? Are they not liking where they are? Are they seeking something? Are they frightened? Whatever. Attention to dangerous items we always have to think about because people cannot protect themselves. People who have dementia cannot protect themselves. So we have to be, this room has not changed. For example, we've been in this room for decades. But now, if a person has a misapprehension about something, be it floor level or types of designs in the carpet or something that was previously innocuous, we have to think about it. Maybe there is something in the environment that is giving them a problem getting around. Maybe it's a rug that they can't navigate anymore. Whatever it is, it makes good sense to pay attention to certainly what really could be a dangerous item, knives, for example, sharp things that people used to just walk around or not notice because they knew how to use them, other things like that. But also keep bearing in mind that edges of steps, clutter that people would normally step around doesn't look like clutter. It looks like some other kind of obstacle, perhaps, or is interpreted that way. Handrails on stairs need to be sturdy. Small throw rugs used are not great. Use rugs with non-skid backing and sturdy footwear. Slippery footwear can be very unsettling to people. And some of these things could actually allow for more freedom for people to move around and perhaps less agitation. Assess for and attend to other potentially dangerous items. Medications now have to be in an inaccessible place, even over-the-counter stuff. Vitamins, anything. Dangerous chemicals, household products, that should be products, matches, etc. Alcohol, plants, even though we like them and we know what to do with them, other people may not understand that they're poisonous. And certainly any weapons or something that could become a weapon. Next, please. Often our first step has to be to try to reassure the person. And when, as a caregiver, we're super stressed out, I was supposed to be at this appointment half an hour ago. Now I'm still here trying to manage this, stressed out in all kinds of ways, to remember to try to use calming phrases. Because you're not yourself calm. And letting the person know that you're there. Not understanding that somebody I know, I may not know that I know them, but somebody who can now convince me in some way that they're familiar to me is here with me. I'm not alone. I'm not with strangers. Find outlets for energy, such as taking a walk, because people do, people still have energy. And if you're sitting in a chair or in bed all day, something's got to give. Doing household chores, some meaningful activities, maybe some repetitive activities, folding things, whatever. Involve the person in activities like art, music, or therapeutic touch, if that promotes a relaxation for them. It might be good for caregivers to do that on their own, for themselves. Allow adequate rest between stimulating events. Too much is too much. Most of us are used to, just being so busy all day. But if you're having to process things at a different speed and you may not be sleeping well, it's really important to pay attention to what the overload might be for an individual. Next, please. Okay, these things I'm thinking so I don't know how, whoa, 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 whoa. I'm no longer with you. How did that happen to me?
We can hear you, Dr. O'Toole.
But I can't see you. Where did it go? Okay, sorry about that. So simplify the tasks and structured routines. So step by step, say, we're going to do this today. Let's start with this. Very simple. You're not going to start with the overall project. You're going to start with a little piece of it. Like we're going to fold something. We're going to work with a busy quilt, or we're going to start to get, if you're cooking and somebody can still help with cooking, we're going to set the table. We're going to get the ingredients out. Here, you hold the flour, I'll get the disc. Really simple stuff. Provide clear instructions, simple choices. Use signs and labels to cue or remind the person. They work up to a point. They do. When somebody, the reading doesn't help them any, or the signs are not cutting it anymore, then, I mean, some of these things become less important and less useful. Remember to use that lighting issue that we talked about before, but have a thought to what's confusing and what's not confusing. You think sometimes that bright lights will be helpful because it's clear, we can see things, but it might also be a glare or a disturbing thing for people who are not wanting to be in bright light. It also, we have to think, there's a thing called circadian rhythm, which is how our bodies orient towards the day, really from daylight to nighttime, which is obviously a contributor to wakefulness at night and difficulty sleeping. So lighting is important. And sometimes we use a lot of light at night because we're worried about people getting up and falling and that sort of thing. We have to be conscious of, does that also contribute to them not knowing that this is nighttime and they should sleep? Restlessness, especially at night, can be enhanced or made worse rather by lighting. It maybe have a whole host of other issues. Going to the bathroom, that sort of thing. Attend to lighting to minimize misinterpretation of things. And use strategies to de-escalate. Think about before or after you have if we have an experience of somebody really going sort of super distressed and angry, agitated, upset. Do we know what could possibly help them? What helped them before they became impaired in this way? What was a distractible thing to do that they would engage in readily? Interesting. Sometimes people hang on to their misperceptions, but oftentimes they can be distractible, and giving them another thing to think about that's pleasant to them or that's less threatening, it can be very impressive in effect. Next, please. Some other considerations, and these are caregiver approaches for both caregivers or perhaps or for the individual. Reminiscence therapy. I used to do this a lot with folks, including family members. Sometimes the old stories are still there, and let them talk about old stories. That's fine. That people feel like they are contributing, and there's some exchange. Look at old photos. Listen to music that people really like or liked in the past that may bring them in their head to a different place. Music has an effect on people in terms of time and place. Aroma or music therapy, as we mentioned, sometimes making music, and smile. I always mention this because I found it to be a really useful tool that can change the way things are going. Calmness and a smile is something people understand. Even if they have severe impairment or distress, a smile that appears to be a genuine smile, it's hard to not smile back, or it's hard to not think positively in the face of a smile. Next, please. So, adjustments for caregivers in terms of approach. Understanding disturbances as responses to a discomfort and helping to figure out the discomfort, because in some ways the caregivers are the agents on the scene in a lot of ways who can bring good information to the table to discuss options. Are there unmet needs happening? People really, speaking of going to the bathroom, do people have to go to the bathroom? Don't know what to do about it, but are uncomfortable? Is there some other, are they hungry? Are they cold? What's going on? Is there some unmet need? Attempts to communicate. I can only imagine what it would be like to want to communicate something to somebody, particularly somebody I care about, and not be able to do it. I have some language, I have some words, but they don't seem to get what I'm telling them. Or I don't know how to tell them because I don't understand it myself. So attempts to communicate are important on both sides. Figuring out what the attempt to communicate is and finding additional opportunities and types of communication. Is the individual feeling overwhelmed? Is it just too much information overload, stimulus overload, those sorts of things? Next, please. I always stress this, and forgive me for being repetitive, but it's so true. Caregivers are going to be the best at crafting a patient-centered approach. Providers can craft a patient approach, a care approach, but not necessarily patient-centered. And the best approach is going to be patient-centered. Caregivers who know and care about the patient are uniquely able to be helpful and interpret appropriate responses. Unfortunately, they're also uniquely at risk for being hurt in these situations. So whatever we can do to help caregivers understand that people have an understanding and appreciation for what they do. Next, please. So because caregivers are so important, and often they are the ones who are left taking care of themselves, they have to attend to their own health and ability to tolerate the stresses and recognize that sometimes you have to take time out or do something to address those issues because they encounter them daily in dealing with care for a person experiencing BPSD. Sharing burdens when possible can be helpful. A lot of folks are, this is mine to do. I don't want to burden anybody else. You know, sometimes people are willing to share burdens and they don't even understand what you're going through if you don't if they can't have an inkling of it. Sometimes people won't even lift a finger, but you've lost nothing if you try, I think. Caregivers should seek assistance with strategies and coping when needed. It's hard to do this on your own. It's impossible in many ways. It's often difficult to remember that BPSD is a result of the disease and not volitional on the part of the patient. It feels personal. And what's said might strike chords, but it isn't the person. Evaluate and reevaluate as behavior and abilities may change over time. Try things, they don't work, they don't work. Try things, they work, and then they don't work. Time's changed. A new approach is necessary. Next, please. You all know this, but I got to say it out loud. Caregivers are doing a very hard job. That is recognized, although it might not feel that way all the time. Sometimes it's important to just slow down, take a beat, think about things, other things, breathe. Decisions can be discussed and shared. There are various people who can help. I know our staff are great at that. And they can give ideas as to where else that can be found. Consider also, where does the caregiver's strength come from? Where's the support for the caregiver? Is it their mental toughness? Is it their religious beliefs? Is it their social circle, which may shrink under this caregiving business? Where is it that that strength comes from, and what can be done to shore it up? So many decisions involve, as we said before, a careful assessment of risk and benefit. And I think one of the challenges is not only is that a difficult balance, but we have to consider who bears the risk, because behaviors and treatments, there are some risks to the patient of both treating in certain ways and not treating in certain ways. And there are risks to the caregiver, either not treating or some other aspect. And the benefit's the same. That's hard to do all in one's own head. But discussing it, thoughtfully going through it, is probably going to be worth a while. And consider seeking help to sort out the options as necessary. Next, please. Okay, I put some references at the back here. There are not too many of them are super scientific. I tried to pick some that would be accessible and interesting or might support what the audience was thinking about. But if there's a question about anything I said and you need more references, let me know. Next, please. All righty, you made it. Questions, please.
Okay, let me go to our questions. Okay, one question, Dr. O'Toole. Are psychotropics useful in the care of the patient with dementia, or are they considered useful as a last resort?
Well, we don't use, they can be helpful. They can be useful. They have consequences, as we talked about. And one of them is that black box increased risk of death. Although dementia itself increases the risk of death. So yes, it's an increased risk. And I reviewed the literature on this before today. And it's an increased risk, but it's hard to know how significant it is given the progression of the disease itself anyway, and the outcomes of the ultimate progression, and the quality of life as experienced by both the patient and the caregiver. And in a lot of situations, the patient in cognizant life would be very much wanting to value the caregiver's experience as well. So yes, they can be useful, but we do try everything else before that. We certainly do want to consider that route strongly when safety is a big issue. Safety for caregiver, safety for patient, violence, that kind of aggressive thing, wandering as in outside, at risk for heaven only knows what could happen. Those are circumstances where we really do consider it, and do use them. But even so, we always want to continue with the non-pharmacological supportive approach as well.
And another question that relates to the psychotropics too is, can a patient with dementia give informed consent for treatment with psychotropics?
Probably not, because if they need psychotropics, it's not like when we were looking to that, it's usually moderate to severe dementia. So I would always ask a person for the sake of what can they bring to the table to have about this conversation. For example, if patient and caregiver tell me I absolutely will not take a medication, absolutely no go, never have, never will, we got a problem if we want to think about antipsychotics. But if there's somebody who will take a medication that's recommended and they have an ability to listen, and we think this will help you, even though we don't think they can really assess all the necessary elements of a decision-making process, well, let's try it and see, which is really what we're doing. I would never lie to a person, no matter what their cognitive status is, but I don't have to tell them every nitty-gritty detail that they can't understand either, as long as I have a viable decision maker who is making the decision on their behalf. That's why we also stress advanced directives, and especially the durable power of attorney for healthcare, because that allows patients, usually earlier on, I try to do this as early as possible, to make a choice of somebody they trust to make decisions when they couldn't. And then you can feel like, okay, I've got a decision maker who is invested in making the best decision for this patient. Does that make sense?
Mhm.
Okay.
Another question, is there harm in validating if someone has dementia and they're having visual hallucinations, is there harm in validating them as long as they are safe? My mom sometimes thinks her deceased parents are in the room and we tend to play along.
Yeah. Why not? I don't see a downside to it. You're not going to make them occur more often. If somebody is distressed by it, that's a different story. Then we have to do something. But if it's somewhat of a benefit, and it's hard, it's hard for me to know. When we think about hallucinations, we think about somebody, we think more in terms of like schizophrenia, when people actually are seeing things that are telling them to do things, or seeing things that are not necessarily just visual. But for people with dementia, sometimes it's more going back in time. And that's what my husband used to be sitting at the table there. Every night we were sitting at the table there. So I see him there now. And it's comforting to me to see him. I think that's a fine idea to support that if it makes sense. If it doesn't, then you have to do something different. Quality of life is the main driver here.
Okay. Thank you again, Dr. O'Toole. I want to encourage, anyone, your family member, your friends, if you have questions, please reach out to myself, Hannah, or Cassie. We can further discuss our programs in the best way that we can help you. In addition to us, these are our providers here, so more resources. Dr. O'Toole, obviously, who just did the presentation. Dr. Botros, who's also a geriatrician, and then Dr. Orlasky, who is our geriatric psychologist. Some of you may know Pamela Lynch. She's a facilitator for our Caregiving with Confidence workshop. Our next session starts June 18th. If you're interested in signing up for those courses, 6 weeks, please reach out to us and let us know. And then Carol Klingler, founder and CEO of Life, a dementia-friendly foundation, and she's also a master trainer for Dementia Friends, Ohio. These are additional resources: our Caregiving with Confidence workshops, our dementia support group, which is the second Tuesday in the afternoon, and then we have one in the evening, and then also the fourth Tuesday in the afternoon, Alzheimer's disease and dementia support program, supportive home care program and respite care, brain health and wellness, which you just saw. Our next one is going to be on June 26th, and it's going to be on living in the moment. Our memory cafe, which is the first and third Thursday of the month, and then Medicare CMS guide and dementia care program. This is for our next brain health session. Carol Klingler will be presenting. And thank you everyone so much for attending. Please reach out to us with any questions or concerns.